Welcome to Better Health Guy Blogcasts, empowering your better health. And now, here's Scott, your Better Health Guy. The content of this show is for informational purposes only and is not intended to diagnose, treat, or cure any illness or medical condition. Nothing in today's discussion is meant to serve as medical advice or as information to facilitate self-treatment. As always, please discuss any potential health-related decisions with your own personal medical authority.
Hello, everyone, and welcome to episode number 79 of the Better Health Guy blogcast series. Today's guest is Dr. Kelly Halderman, and the topic of the show is Phase 2.5 Detox. Dr. Kelly Halderman completed a family practice medicine internship with the University of Minnesota and has a Naturopathic Medical Degree from Kingdom College of Natural Health, where she is the current academic dean of students. She holds certification in MethylGenetic Nutrition by the Nutrigenetic Research Institute and certification from the American Functional Neurology Institute in Functional Neurology and Neurofeedback. She is the lead researcher for the Nutrigenetic Research Institute and also sits on the board. She is currently working on completing her Ph.D. in clinical nutrition and has certification in plant-based nutrition from Cornell University. Her interests include cancer and chronic Lyme, of which she has personally experienced and beaten. She does consultations for those interested in optimizing their health. And now my interview with Dr. Kelly Halderman. I have had Bob Miller on the show previously, and he's so full of knowledge around complex chronic illnesses. Dr. Kelly works closely with Bob Miller and has some great information to share with us today about Phase 2.5 Detox, which I think is something that most of us probably have not heard before. So thanks for being here today, Dr. Kelly.
Thanks for having me, Scott.
As I understand, you've had your own journey through chronic Lyme disease and you're doing really well today. So tell us a little about what that experience of having Lyme was like for you, what some of the things were that you found really helpful in your own personal recovery, and how you're doing today. How did Dr. Kelly beat Lyme?
Sure. So it started around 2010 when I was working in traditional medicine. And I started to have really strange symptoms, neurological symptoms out of the blue, like foot drop and paresthesias and migraines. And all of a sudden my thyroid stopped working and I couldn't figure out what was going on. It was chalked up to stress. I knew it wasn't stress. I was eventually given a diagnosis of MS and a box full of pharmaceuticals and basically told by my colleagues to go home and get my affairs in order, spend some time with my children. So basically a death sentence. That was not okay for me. I knew that in medicine we were doing amazing things. And basically when it came down to trying to get to the root cause, we were not so good. I needed to find out what was going on and what was causing this. So I actually had to take a step away from medicine. I went back and got a naturopathic medical degree. I used those principles and practices such as nutrition, which was completely new to me, to dig myself out of that deep trench of disease. I have many people to thank, and I had a fabulous Lyme literate physician who really helped me in 2012, and definitely very, very grateful to her. That was how I started, is getting the proper diagnosis. And also, I have to thank my husband and my family for sticking by me definitely through this. It was a journey. And, a couple of years ago, we were celebrating how much I had recovered, and my husband and I decided, let's have a baby. So 2 years ago, we welcomed another child, Lyme-free. He is a 2-year-old rambunctious little guy, so we feel very blessed about that. But I would say that really how Dr. Kelly beat Lyme basically came down to two things, Scott. And number one was I had the good fortune of training with a world-renowned trauma surgeon during my medical residency. And he was a legend. He was at the end of his career and had seen everything. And we were on call, trauma call, we'd run down to the emergency room in the middle of the night and we'd see people that were in horrific accidents. And he'd look at me and he'd say, as long as they're still breathing. And it inferred so much hope in that just because they were breathing, this was huge. And this was something that we couldn't take for granted. And so in my deepest, darkest moments of being in so much pain and having my body feel like it was falling apart, it sounds a little silly, but I really clung to that, is that I was still breathing. And with that, it was a miracle that I was, and I had so much to work with. And I coupled that with my body is designed to heal. So those are my mantras. I am still breathing and my body was designed to heal. And I was really thankful that I kept that mindset as hard as things, were for people with chronic Lyme. And number 2 is what we're going to talk about today. So the second thing of why I really think that I beat chronic Lyme, in that the amending and maintaining of what I call phase 2.5 detoxification. When I got this right, it catapulted me into really extremely good health. And I'm excited to share that with you and the listeners today.
Awesome. Thank you. Yeah, that's a powerful story, and it is hopeful, and it's hopeful for other people too when they can see someone like yourself that's come from a place that was really challenging to where you are today, that they can also get to a place of recovery. So let's talk a little bit about the different phases of detoxification. So we're going to talk about phase 2.5. Most people have a basic understanding maybe of phase 1 and phase 2, but let's step back and talk about those. So what are phase 1 and phase 2? What do they do for us? And then what are some of the things, maybe some nutrients, maybe other tools that we can use in support of each of those phases?
Sure. So let's revisit those phases. So phase 1 is basically activation. So if you think of it as phase 1, 2, and 3, we have activate, conjugate, and then excrete. So phase 1, we're taking endogenous compounds such as hormones or exogenous things such as toxins and drugs, and we are changing them into a little bit more reactive because the goal is to get them to be water soluble because they're going to be excreted in the urine or the bile. So the process of hydration, hydroxylation, oxidation, that's phase 1. And again, making it a little bit more reactive. We need nutrients such as our B vitamins and flavonoids to make this go smoothly. And then on to phase 2. So phase 2 is the conjugation. So we're taking that molecule that was transformed in phase 1 and we're actually making it water soluble so it can be excreted. That depends on glucuronidation, methylation, acetylation, amino acid conjugation. So that's a big workhorse is phase 2. The nutrients we need a lot of sulfur. We need glutathione. We need adequate levels of folate and choline, just to name a few. And then finally, we have phase 3. Phase 3 is where the toxin has been nicely packaged. It's moved into the bile or into the urine through the distal tubule, and it needs to be excreted out.
So we have a toxin that's gone through phase 1 and 2. Let's talk a little bit about what happens next. So what is what you call phase 2.5, which I think is somewhat of a new term. I don't know that that's conventionally recognized yet. Maybe it will be from your work. So is a deficiency in this phase 2.5 what some people think of as cholestasis? And is the goal of phase 2.5 to get these now conjugated toxins into the bile, into the gallbladder, so that then they can move on to phase 3?
Okay, so once the endogenous or exogenous compound has become water soluble, it's ready for excretion. A paper that I read earlier this year in Townsend Letter by Shade and Decker, as well as a paper that I really reference a lot by Dr. Boyer in 2013 on bile formation and function, taught me about the MRP2 membrane channel. And that protein channel sits on the canicular membrane. So it sits on the hepatocyte, is connected to the where the bile goes. And the conjugated toxin needs to move through that channel in order to get into the bile. So that right there is part of 2.5, having the movement of the toxin that had been already conjugated, and it's water soluble, having it move through that channel. Now that is a really metabolically demanding process. That is a part of that channel. The MRP2 is part of the ABC cassette binding protein, meaning it needs a lot of ATP. So that movement needs to be coupled with the movement of bile salts through the BESP channel, as well as movement of phosphatidylcholine. So those all three have to move in tandem. Get that beautifully packaged toxin actually out into either the bile or into the urinary system. So cholestasis is actually a medical diagnosis. It can be extrahepatic or intrahepatic. So if you have something like biliary atresia where your bile is not moving, cholestasis. Cholestasis may be the fulminant expression of when phase 2.5, which is a normal process, isn't working well.
So the three things then that are needed to execute phase 2.5 detox, you just talked about them. So it's the bile-laden conjugated toxins from phase 2. It's the MRP2, the production of bile, and then the production of phosphatidylcholine so that there's the flow of bile, correct?
That is correct, exactly. So 3 things put together make up 2.5. Movement through that MRP2, movement in tandem with the bile salts, and then phosphatidylcholine makes it nice and not sludgy, to be just to use layman's terms. And what's really interesting is how I stumbled upon this. So I kept seeing SIBO patients returning to my office after they'd been treated for SIBO. It was like the SIBO revolving door. And I went back to the drawing board and I started to study bile a little bit closer after my friend and brilliant colleague, Dr. Eric Balkavich, gave a talk at ShyCon, the most recent ShyCon, on bile. And I thought, this is something important. Let's study this. So looking at the function of bile, and that paper by Boyer just completely blew my mind about how bile is like liquid gold, Scott. It is used to maintain the microbiome, have the pathogens have an acidity that they don't like, and have a nice balance. And it does so many other things like cholesterol metabolism, thyroid metabolism, and other things that were really important, and I really didn't take that quite seriously as a practitioner. So then I went back and I started looking at the genetics of my patients that had SIBO, and lo and behold, they had PEMT SNPs. Now those SNPs are responsible for making choline. Now I don't treat genetics. I use these pieces as clues on how to support function. So it's something where it's like if a patient may not be good at making the PC, well, then phase 2.5 may not be working very well for them. And we're going to talk about how the expression of that when it's not working, things go really wrong. And also they had SNPs in single nucleotide polymorphisms in the pink genes. And the pink genes actually make CoA, as in acetyl-CoA. Acetyl-CoA is your building block for bile. And the last point that's really interesting is that the Nutrigenetic Research Institute just presented at the international conference in Poland at ILADS about the acetylation correlation issues with that in those with Lyme disease. Kind of makes sense.
So let's talk a little bit about bile salts and bile. What's the difference between the two? What is their role in detoxification in general? And then what happens when we don't have adequate bile salts? How do we increase them? And then is the goal to get these conjugated toxins from phase 2 to be wrapped with the bile so we can eventually get them to the gallbladder and get them out of the body through phase 3?
Sure. So bile is composed mostly of water, 95% water, and 5% of it is actually organic and inorganic solutes, and one of those are bile salts. Bile salts are synthesized from cholesterol by the P450, the enzymes in there. And it's important. And again, you can't stress the importance of bile. I really didn't. I took it for granted, and how it does everything from stimulating the migrating motor complex, so motility of the gut, keeping that environment nice and friendly for the microbiome, emulsifying and digesting fat, regulating glucose and cholesterol, and again, thyroid activation of the hormone in there. So it all really starts with that acetyl-CoA and how that will be the building block for it.
So how do we then optimize, knowing that bile is so important? How do we optimize our production of bile? What does the body need to actually create it? And are there cases where we should consider taking things like ox bile exogenously or in a supplement form?
So we start increasing production of acetyl-CoA is really the short answer, is that's really the building block of bile is acetyl-CoA. Acetyl-CoA does so many things. It's the beginning of how we make ATP. It also is responsible for acetylating histamine and other things in the liver, so it has phase 2 capability as well. And we're in a closed system here, so we have to make sure that we're in balance, and we're going to talk about that when we talk about the mast cell and all the histamine that needs to be mopped up. So you can look and see if you have genetics at your ACAT gene, an ACAT enzyme, and just see if it's working well or not. And so my ACAT genes, enzymes, as per the report from the Nutrigenetic Research Institute, mine aren't working so well. So at times I'll use things like acetyl L-carnitine to help with that. And you can also use calcium pyruvate, because if you really want to get biochemically technical, so pyruvate goes to acetyl-CoA through the pyruvate dehydrogenase. enzyme, but you have to be careful because not everybody's PDH is working well. So if you're flooding your body with pyruvate, it's going to back up and cause lactate. So you're going to need a savvy practitioner. And I know a lot of your listeners are savvy, so they might understand that. But and lastly, for the PANK enzyme, pantethine. Take pantethine. Regarding the ox bile question, that's a fantastic question. So when I was 20 years old, my gallbladder was taken out. I still don't know the reason why, but basically the bile built up in my system when I was taking it. So this is the caveat, is that I probably wasn't making bile salts very well, but that they are designed to be recycled. But when they accumulate in the blood, what they can do is increase TGR5, which will actually increase conversion of T4 to T3. So you can get a little bit of hyperthyroid symptoms, and then you can burn out your T4 stores and become a little hypothyroid. So you can use ox bile as a Band-Aid, but I wouldn't rely on it. I try to get your own metabolism, your body's own ability to make those bile salts going.
And then where do things like bitters fit in? Coffee enemas, are those helpful from maybe moving bile more so than actually creating bile? Do those things play a role here as well?
Sure. So, if you want to use things like, let's say you're going to use the bile salts, things like TUDCA. But if you're interested in moving the bile, so let's just say that you're making and recycling your bile, but you need to move it. You can use things like bitters. Artichoke has amazing science behind it and how it can help with this problem. Coffee enemas, visceral manipulation, and other modalities that can really help just push that bile through. And milk thistle, of course. Milk thistle will actually help stabilize that MRP2 channel. So it's like a 2-for-1 with that.
But what's the role of the hepatocyte? Where does the bile that moves to the bile canaliculi end up, and how do we stabilize this to optimize MRP2? And you were just talking about the milk thistle and the TUDCA. I know those play a role here as well.
Sure. So the role of the hepatocyte is vast. I mean, it is doing things that we don't even know that it's doing. And so one of those movements, or one of the functions of it, is to have that MRP2 channel to push the bile through into the caniculus. So you have that movement in the hepatocyte, in the liver cell. It's pushing those toxins through the MRP2 into the bile. The bile is being excreted into the intestine, and hopefully it doesn't get reabsorbed. So we have to really make sure phase 3 is being respected, and then it ends up in the toilet. So things that can help stabilize that membrane channel are things like you said, like milk thistle can really help stabilize, as can TUDCA. But again, be careful with loading up on a lot of bile salts. And it can really help. You know what I've seen? I've seen that when you're getting this bile flow working, I myself was on thyroid medication. I have Hashimoto's. And when I started getting the bile working, I actually, my digestive issues went away, and I actually started reacting negatively to my thyroid medication because I didn't need it anymore. So I would just be mindful with your practitioner, with your licensed practitioner, that if you're going to be doing some of these things, this is high level, and you need a really savvy practitioner to kind of help you. But when you get things going and the way that they're designed, just be mindful of that.
So once we have the bile made, we have MRP2 optimized, and then we need to move the bile with the phosphatidylcholine. So what are the things the body needs to make PC or phosphatidylcholine? And then is that also potentially something that we should be supplementing? I know a lot of people do supplement with PC.
Sure. So when it comes down to it, we need a fully functioning PEMT enzyme. And of note, every person I've ever seen with SIBO has homozygous PEMT SNPs. And again, I don't treat genetics, but it's interesting that, they may not be making their phosphatidylcholine. So, of course, I am a fan of getting our nutrients from food. So I try to get my phosphatidylcholine from eggs and liver. Now, a lot of people have a lot of dietary issues, and so they can supplement with PC. A clinical pearl is that I measure phase angle. Since phase angle shows the health of the cell membrane, and the cell membrane, the component is phosphatidylcholine. I have seen the phase angle, the cell membrane's health get better as we supplement with PC or we're trying to get that in the diet, seeing that go up. So
And
practitioners.
that's with the bioimpedance analysis that you're measuring phase angle, right? Yeah.
Mm-hmm.
So let's kind of sidetrack then a little. You've covered some of the SIBO discussion, but I want to be really clear for people on this. So you mentioned that bile is important for motility. So in SIBO, in people with constipation issues, potentially supporting leaky gut even. So does that mean that if we focus on moving bile, that potentially could replace or minimize the need for these prokinetics when you're treating SIBO? And is bile essentially kind of, I've heard someone else refer to bile as almost like a soap, that it's important in the cleansing process to help minimize the overgrowth of these bacteria and fungal organisms in SIBO and SIFO. So it sounds like one of your observations is that there is an association between SIBO and limitations in bile flow.
Yeah, absolutely. And looking at the genetics, so really combining my background, biochemistry, medicine, naturopathic medicine, and now genetic training, I really do believe that we're looking at the normal function of bile is to stimulate the motility. So if we go after that, if we're going after really optimizing that bile flow, I think it's worth a shot to do that. And you can do it in tandem with things that are stimulating motility. There's absolutely no reason why you couldn't do both and then try and pull back on those things that are promoting the motility and see if you can hold your own, with those or not. But I'm just a fan of honoring the amazing mechanics that we've been given and optimizing that function. But I have no problem with people doing what they need to do.
So you mentioned this SIBO revolving door. So what are a few of the key things clinically then that you've seen have helped bring SIBO cases to more permanent resolution?
So definitely, phase 2.5, and we're going to talk about what causes it to not work well. And it's really tackling those things. So the number one thing that causes the 2.5 to go awry is inflammation. Mm-hmm. And if we don't have the proper bile salts, and then the PC. So really adding in PC is a piece of cake. And really so is putting in some pantethine and making sure that we're making the bile salts. But that inflammation piece and some of the other things are a little bit tougher. But when you're really tackling all three together, I've seen some great clinical success.
So we'll get into those phase 2.5, the things that limit or make that less than optimal. I wanted to get thoughts from you first on if we don't get these toxins from phase 2 through phase 2.5, ultimately excreting out through phase 3, what happens to them? Where do they go? What's the connection between that potential and what we maybe think of as a Herxheimer reaction? And what is this detox-retox cycle?
Yeah, Scott, this was so key in catapulting my health right there, is that I had these well-meaning practitioners, brilliant practitioners, and they kept putting me on, okay, here, take more glutathione, take more phase 1 upregulators, phase 2 upregulators. But my phase 2.5 was broken. So to answer your question, what was happening is that MRP2 channel was actually plucked from the membrane so that it couldn't get into the bile, and it was placed in the membrane where it could get back into my blood. So my body was doing a fantastic job of phase 1 and phase 2, but those toxins were ending up right back in my blood, and I felt terrible. And so really when I started to honor that, like, okay, I just took that. Why? Never stop asking why. That was really key in healing. So that's a detox-retox. Practitioners are pushing, or even people are just pushing detox, but they're just ending up with it in their blood and not feeling well at all. But when I would say that when I was able to upregulate the phase 2.5, I was then able to do some gentle killing, because things were actually exiting out of my body.
Is there any way for us to, through a lab test or similar, to evaluate the function of phase 2.5? I know there are functional medicine tests that will look at phase 1 and 2, I believe, but what about phase 2.5? How do we assess someone's level of function with phase 2.5?
Really, I think that's taking a look at the causes of phase 2.5 and what would be throwing it off.
Okay. And
that's very clinical. From my standpoint right now, I'm assuming that if you're sick and you have, X, Y, and Z for clinical presentation, and we're going to go after those things, and you're feeling better and your gut's working, that was, it's retrospective at this point, but I'm open to suggestions.
The other thing on this whole topic that I found really interesting is actually probably the biggest takeaway I've had in a long time from some of the podcasts was with Dr. Chris Shade, and how he talked about the fact that if this what you're calling phase 2.5 is not working well, and the toxins are then not moving through the gallbladder and into the small intestine for the binders to bind onto, and they are in fact moving back into the blood, that we can take all the binders in the world, but if there's nothing in that area for them to actually bind onto, they may not really be doing much, or certainly not as much as they could be if we were able to bring the toxin and the binder together.
Right. They really need to be used together. So I don't think there's anything wrong with using a binder per se, but you may be wasting some of your hard-earned money just throwing in a binder. I'm really a fan of coupling it together. First, really attending to that phase 0.5, making sure that toxins can actually get into your bile, into your gut, and then binding them. So at first you can do a little bit of binding, and you up them in tandem together. You're going to push more toxins, you're going to make more toxins, and you're going to want to bind them comprehensively.
Yeah, and I agree with you. I wasn't intending to suggest that someone shouldn't take a binder, because I think it is actually really important. And I think it's one of the things many people are missing in their overall health recovery program. But then through the work that you're talking about, we can actually get more bang for the buck, so to speak, with the binders by getting the toxins to the area where they can actually be bound.
Right. And I think binders, I too feel the same way. I think they're so important. I actually created one for myself, and a company, Professional Health Products, thought it was a great binder, and that's going to be available to health practitioners. So phpltd.com. And it's something that I've been looking for forever. And I have always been a fan of binders. I think the 11th commandment should be thou shalt bind. So
what kind of things are in your binder?
Chlorella. We're gonna be comprehensive. We're gonna do clays in there. We're gonna do charcoal. We're gonna do some silica. We're gonna bind the gamut. Like I said, I'm a fan of binders, but it's really hard for your patients when you're telling them take charcoal and take chlorella and I think they feel overwhelmed. It's nice to have a comprehensive binder that you're like, take this. It's covering all the bases. If you by chance don't have, let's say, lipopolysaccharide, if you don't have that problem, well, that's okay, because taking something like charcoal that binds it's not going to hurt you per se.
And it's going to help in other things. Even if you don't have an LPS issue, there's other things that it potentially can. Yeah, absolutely. Okay, so let's talk then about the factors. Let's talk at a high level, the factors that limit phase 2.5, and then we can go into more detail on each one of them. So what are some of the things you mentioned? Inflammation. What are some of the other things that limit phase 2.5?
Sure. So endotoxin. So lipopolysaccharide can excess estrogen. So everyone gets a Dutch test in my office. Some medications, some antidepressants can. The lack of fluidity, we talked about that. So that's that phosphatidylcholine in there. And then the bioproduction.
So the inflammation piece, I think in any chronic condition, that's such a key issue. So it seems like it's central to almost every symptom, every condition that's a chronic health challenge people are experiencing today has some level of inflammation. You've given some other lectures that I've seen about chronic inflammation being when the body cannot overcome whatever the offending agent is, and that continued offending agent, unfortunately, is often the environment in which we live. So talk to us a little bit more about inflammation and some of those drivers.
Sure. So acute inflammation, if I hit my thumb with a hammer, it's a good thing. We have infiltration of white blood cells. We have swelling, redness. That's your body's helping you. But when you have chronic inflammation, it's a completely different story, in that your body's trying to deal with the exposure, and it could be from a biotoxin, it could be from heavy metal, it could be from a plethora of things, but yet it can't overcome it. And it's a chronic cycle. And so, I talk about that, the offending agent being the environment, because take a step outside and breathe the air with the chemtrails in it. Dr. Klinghardt said that he did a study, 7,000 times higher aluminum content in the air when you're having chemtrails around, and our water's contaminated, plastics, and you're looking at the other things, the EMF. Really, our environment is telling us that there's something going on here. And the people who are responding with those ticked off mast cells that we'll talk about, their mast cells are not happy. I think of those as the canaries in the coal mine, and they're warning us about how toxic our environment is. And there's nothing wrong with these people. I don't like people thinking they're broken or something's, the mast cell activation. There's nothing wrong with you. It's your body's doing a good job of trying to alert you and deal with the problem.
And potentially creating an awareness so that hopefully people wake up before it's too late and start cleaning up our environment. I think it's so critical. So then let's talk about mast cells. So what are they? How is chronic systemic inflammation associated to mast cells? And would you say that mast cells are the ringleader or the orchestra conductor from a perspective of ongoing inflammation in the body?
Right. So mast cells, they're from the myeloid lineage. They are immune cells. They're in connective tissue all over the body, and they happen to be most plentiful in certain areas where our body is in contact with our environment. So they are the orchestrators of inflammation because they're trying to protect us. It just so happens that they get activated and we get the symptoms from that, and that leads to big problems.
And so you mentioned that they're in higher concentrations in certain areas of the body. So the gut is a primary one. I think the hypothalamus is another area that's interesting where there's a lot of mast cells as well. And we talk all the time about HPA type issues. And so mast cells, it sounds like they're playing a role there potentially as well. What are some of the things in the body that mast cells are regulating?
Sure. So they regulate dendritic cells, T cells, B cells, fibroblasts, endothelial cells, but the main one that I get concerned about is how they regulate microglia. On the podcast that you did with Dr. Theoharides, you talked about the microglia activation and the mast cell activation, how they feed upon each other. So I'm not going to rehash that. That was an amazing podcast. I would direct everyone to, if they want to learn more about that, to listen to that podcast.
So the mast cells then relative to microglia, it sounds like they're playing a role in brain inflammation, which could be part of the reason people have things like brain fog, cognitive issues, memory issues, all of those things, even maybe including some anxiety and depression associated to inflammation in the brain, correct?
Sure. So when those microglia are activated, they send out a lot of nasty cytokines, and so do the mast cells. And so they play off of each other. Dr. Theoharides talked about how one of the mediators called tryptase from a mast cell is like meat tenderizer. And you don't exactly want meat tenderizer being in the area of all the connections with your neurons. And so, yes, we can see that brain inflammation, that destruction of the normal communication, and the symptoms can be different for a lot of people. I mean, there are a ton of medical research, scientific papers saying that inflammation has a huge role in anxiety and depression. Just Google sulforaphane and anxiety and depression, and you'll see getting the inflammation calmed down can really help with symptoms.
So it's interesting that you mentioned sulforaphane. So I think there's been a lot of conversation about that recently. Dr. Klinghart's been talking about it in some of his treatment protocols as well. And so one of the questions I had about that is, I know that is a phase 2 upregulator. And so if we're introducing sulforaphane, do we potentially have to be even more aware then of optimizing phase 2.5 so that we're not increasing phase 2, but then having these toxins that are pushed back into the blood? Is that a potential concern with sulforaphane?
Oh, that keeps me up at night. That question really, it goes through my mind where I'm thinking to myself, how, looking through the literature, we're getting really good results, but I think we're thinking a little too myopically, because the way my family will consume sulforaphane is through broccoli sprouts. Now, sulforaphane is one compound in there. There are hundreds of other things in broccoli sprouts. So those other unnamed compounds may be helping to stabilize 2.5, because I do see that definitely the people who I really think have issues with 2.5, I'll put them on a small dose, whether I'm asking them to make their own broccoli sprouts or putting them on a nutraceutical, and they seem to do okay with it. But if you go high dose, they don't do well at all, and they actually start to back up, and they'll have brain fog, or they'll get acne, or they'll have referred kidney pain. So I'm seeing in practice pushing it too hard, but using somewhere around 20 milligrams. I think a lot of the studies are doing 60 milligrams. So really playing with your dose and your N of 1, right? So trying to figure out what your doses would be important.
So if we talk a little bit more then about inflammation, isn't it also the case that the more inflamed we are, the less in general we're able to detoxify, that the body can really only be in a state of detoxification or a state of inflammation, but not really effectively doing both at the same time? So we can't really be inflamed and optimally detoxifying. So does then stabilizing the mast cells and reducing histamine and so on, does that positively affect our ability to detox, in part because inflammation is now reduced, which is then helping to upregulate phase 2.5?
Definitely. I've seen that over and over in clinical practice, where really detoxing, like pushing it really hard without trying to quench some of the inflammation, it doesn't work very well, and people feel sicker and sicker, and then they take more and more supplements. So I don't see it as black and white. I see it as a balance, but definitely go for the inflammation first, I think.
And so would you, in some cases, use anti-inflammatory compounds as well in order to better support phase 2.5? It sounds like you would.
Yeah, I would.
Okay. What are some of the, from your perspective, the key things that seem to trigger the mast cells to release histamine and all of these other mediators that lead to inflammation?
Sure. So biotoxins is huge. So we know that toll-like receptors, the Lyme can hook on there and they can cause a degranulation, viruses, H. pylori. I mean, the World Health Organization says that half the population has H. pylori. So really, we're looking at a lot of things that can really tick off these mast cells: heavy metals, lipopolysaccharide, neurotensin, substance P, complement, and then our traditional IgE cross-linking, such as I have a peanut allergy or an egg allergy, where that ends up with anaphylaxis. I will say that stress definitely can degranulate the mast cells through the corticotropin releasing hormone. And so I have a t-shirt and it says, "Keep calm and try not to degranulate." And I do, I literally do. I think it's so important. And I really poo-pooed all the stress stuff and didn't really, pay too much attention to it. But it's very, very important. And, just getting caught up in traffic can degranulate your mast cells. So
wow.
You have to really...
and another one that I got out of the podcast with Dr. Theo Harides is the exposure to electromagnetic radiation, electromagnetic fields, Wi-Fi, cell phones, all of these things. And so, there are things that unfortunately are just part of our environment. Nonetheless, we should potentially continue to focus on attempts to reduce those. So with EMFs, maybe we can't get rid of them completely, but doing some things and taking some steps to minimize our exposure, I think certainly is helpful.
Yeah, I would say that in the last 3 years, my family and I have spent the most money, not on supplements, but on protecting ourselves from things like EMF and having better water and better air. And that has been fantastic. So yeah, EMF definitely degranulates the mast cell.
In your clinical experience, what are some of the symptoms that present in patients when they have this mast cell issue and degranulation? What are some of the key things that you're seeing?
Sure. So it could be a plethora of things, but I see things like flushing, itching, rashes, nausea, vomiting. I mean, really, the list is so long, and it's not exclusive or inclusive. So you can really, there's a diagram, and it shows the 4 receptors for histamine. Histamine is one of the mediators for the mast cell. And the far-reaching effects of just that one mediator are incredible. So you can imagine all the downstream symptoms someone can have when they have that degranulation.
How do we then lower the burden of histamine in the body? Are there some things that we should be doing to help reduce that?
Sure. So I would say a low histamine diet. So the low histamine chef, I think it's healinghistamine.com. His website was fantastic for me when I was trying to lower that burden. And I still do here and there have to pay attention to how much histamine I'm eating. And the DAO enzyme that can help mop up or metabolize some of the histamine in our gut. And then really what I think is really key, Scott, is that acetyl-CoA, we talked about how it goes down the electron transport chain and it makes ATP. Well, acetyl-CoA also makes bile. Acetyl-CoA what I call the acetyl-CoA steal is sometimes stolen to help mop up all the histamine from the degranulation of the mast cell, from us taking in too much histamine endogenously, like eating it. So really mopping up that burden can help free up that acetyl-CoA to go down the electron transport chain to make more energy, because we know that the sickest of the sick, we're tired, and that may be coming from mopping up all that histamine. So that's why it's important too, to really free up the acetylation, and the acetylation is used to silence retroviruses as well.
So if we have these higher levels of histamine, the acetyl-CoA then is stolen to address that issue, resulting in lower levels of ATP, resulting in low energy and fatigue. So knowing all of that, how do we make more acetyl-CoA and how do we optimize acetylation?
Sure. So the Research Institute found the SNPs with the NAT gene, NAT. So that's N-acetyltransferase. So that's where it takes the acetyl-CoA, it takes off the acetyl group, and it hands it to histamine. Histamine we can get rid of that. We can optimize that by optimizing how much histamine we're putting into the system. So really, just like we talked about, making sure that we're trying to limit the degranulation of our mast cell, which is environment and stress. And then the ACAT enzyme as well. So ACAT can be supported with acetyl L-carnitine. And then lastly, the PANK enzyme, and that's supported with pantethine.
Excellent. So now that we understand that the mast cells really are important in inflammation in phase 2.5, we've talked about the histamine piece, but how do we stabilize the mast cells, thus reducing histamine? So are there any favorite ways that you have for stabilizing the mast cells?
Oh, absolutely. Luteolin. I mean, the science behind that, Dr. Theodoridis talked about that compound is amazing. Some quercetin, diet, of course, to just lower the burden of that, and stress management. I can't stress that enough. The stress management is a key piece of really helping with that.
So one of the other areas when we talk about inflammation affecting phase 2.5 is the whole discussion about iron. I know that Bob Miller and Morley Robbins, they talk about iron toxicity. What are your thoughts on this whole impact of iron on inflammation, and what should we potentially do from an iron perspective to also reduce inflammation?
Sure. So in the 1941, they started putting a lot of iron in our food, and then again in 1969. So I happened to meet Morley Robbins in the conference I was teaching with Bob Miller and Sanibel, and he really started to explain this to me, and I was really shocked. And so it really was a paradigm shift for me in how I knew that iron was setting off the Fenton reaction and causing the hydroxyl radical to be made. But I didn't understand how the iron was being dysregulated and what that meant for our energy production, and how copper, the availability of it, is very important too. And that's another podcast in and of itself, trying to explain that. But I really think what was interesting and Morley taught me about this is that those inflammatory mediators, such as TNF-alpha, interleukin beta, interleukin 1 beta, and IL-6, what they're trying to do is they're trying to increase the bioavailability of copper and decrease iron. And we know from the Nutrigenetic Research Institute that we have found in our studies, the HFE enzyme was more prevalent, the SNP was more prevalent in those with Lyme. And so that kind of fit together with me. I myself also have a solute carrier issue where I can't get iron out of the cell. So I'm looking at it like I have copious amounts of iron. I actually had iron infusions along the way during my health journey. So I'm really full of iron. So, Morley taught me about how we need to drain the swamp, and we need to make sure that we're taking in bioavailable copper. And I do that through nutrition. So it's a really complex process, but it really is.
And I've had Morley on the podcast as well, and he's a passionate a source of lots of good information. So people that are interested can listen to that. So talking more then about reducing inflammation for phase 2.5 optimization, we need to stop the activation of the mast cells. We need to clean up our diet. We need to stabilize the mast cells with nutraceuticals. You mentioned luteolin. We need to optimize acetyl-CoA and acetylation. And then we have to think about this whole balance between mTOR and autophagy. So what is mTOR and autophagy, and how does it fit into this discussion?
Sure. So mTOR stands for mammalian target of rapamycin. So it's basically the master of your body's metabolism and cell growth. I think of it as the construction crew. And the opposing mechanism, which won a Nobel Prize in 2014 for the work by Yoshinori, is called autophagy. And autophagy is the cellular cleanup. And so when we're stimulating mTOR, this is key. We're shutting down the autophagy.
So is it then the case that whenever we're stimulating mTOR, autophagy is getting reduced, or is there a way to have some balance of both of these efficiently operating at the same time?
So I definitely think that there's a balance. I think that with people with chronic disease, we probably need to upregulate their autophagy because we live in an mTOR-dominated world. Look at the plastics in our water. Some people overdo protein drinks, the pesticides, the glutamates. We're really in the EMF. We're overdriving mTOR and perhaps shutting down autophagy. So if we can ease up on our mTOR, and I wrote a paper and it's on my website, drkellybeatlyme.com, where it's really simple and you can print it out for your patients, and it says how to just decrease, just ease up on your mTOR, and then things that we can do to bring up autophagy. So for the easing up on the mTOR, I like to use resveratrol, quercetin, and turmeric. And then for the autophagy boosting, fasting, lithium, and berberine.
So let's talk a little bit more. You mentioned protein shakes specifically. So I think there are those people that, myself being one of them, that over the years really benefited a lot from a power shake. I wouldn't necessarily call it just a protein shake, but using some protein powder, using a number of healthy fats, using chia seeds, using fibers, using phosphatidylcholine, for example. So how can we still get the benefits of something like that without the risk of sending the janitorial staff on vacation or reducing autophagy?
Yeah, and again, I think it comes down to balance, Scott. I think that if you're benefiting from that protein drink, just take a look at all the other things that can push mTOR, such as EMF, and try and just downregulate those. And then have times where, if it's okay with your practitioner, that you really go after autophagy and you really go after boosting that. So we're just kind of, it's not good or bad. It's just really trying to have those work for you in your favor.
And then what's the connection between autophagy and Bob Naviaux's work with cell danger response?
Sure. So the cell danger response in a nutshell is that primordial response to a decrease in electron flow. So the body's on red alert because something's happening. It noticed that our mitochondria, the electron flow is decreasing and it needs to do something. Goes into that siege mentality where it shuts down things on purpose. The thyroid, for instance, the gut. And so one of the downstream effects that Dr. Naviaux found, there's 8 of them that he published in his paper. One is that the body during the cell danger response is trying to upregulate autophagy. And I'm thinking to myself, I know I was stuck in the cell danger response. I mean, we go in and out of the cell danger response all the time. When we get the flu, we're in it. But when you get stuck, that's not where you want to be. So I noticed that if that's one of the downstream effects, what the body is really wanting to do, well, then why don't we do it for our patients? And getting a lot of clinical success, really, really trying to optimize that autophagy was really important and still is in my practice.
So wrapping up then on the things that might affect phase 2.5. So we covered inflammation, we covered lack of fluidity, we covered bile production. Maybe you can comment a little bit more on the endotoxin piece, the excess estrogen, and the medications and how those play a role as well in phase 2.5 detox.
Sure. So the endotoxin, or the lipopolysaccharide, that outer membrane of the gram-negative bacteria, that stuff's nasty. And it can shut down detox. It can shut down it can degranulate the mast cell. So really getting your gut in order is obviously very important. Every one of your listeners know that. So we really can't neglect the gut, and I don't think anyone listening probably does. It's just a reminder that we really need to make sure we're feeding ourselves well, that the terrain is being supported. And then with the estrogen, that's just something that I learned from the Townsend letter, and I just do a Dutch test and make sure I'm mopping up and helping the patient if they have any estrogen issues, just tending to that. And then the medication issues. So that could be stopping the phase 2.5. And I tend to not touch that with a 10-foot pole, but just really make them aware of that could be shutting down this biochemical process.
So now we're going to talk about phase 3. So phase 3 is about getting toxins out of the body. So we go from the liver to the gallbladder to the intestines to the toilet, or from the kidneys to the urine to the toilet. So as I understand, the body is recycling a lot of the bile, that it's not inexpensive for the body to create bile. And so we have this enterohepatic recirculation that can happen. Part of the reason that binders are so important, so we're not reabsorbing many of these toxins. So talk to us a little bit about the importance of binders relative to if we finally do get through phase 1 to 2.5 and we're working on 3 to limit that reabsorption potential.
Right. Just think of it. You have perfect phase 1, phase 2, 2.5, and your body just delivers this perfect toxin and the bile is flowing. And then you don't bind it and it ends up back in your bloodstream. Not good. So we really want to respect that. Again, the 11th commandment, we have to bind. And so in practice, that's something that I make sure that I'm covering that base. I think binders are important for everyone who lives on planet Earth at this point. And that having a comprehensive binder is really important. And I know you feel that way too. So, you can use things just like charcoal and that's fine, but we wouldn't want to miss anything. And that's why I really believe strongly in using something that has a lot of different reach.
So talk to us a little bit about the individual binders that you might use with patients. I know you're working on this formula, which sounds great, but which binders might be helpful for different types of issues, different toxins, mold exposures, those types of things? What are you clinically using?
Sure. So, you can look at labs. You can do heavy metal challenges to see if there's heavy metals, and you can use chlorella is great for that. You can use charcoal if you think that they have lipopolysaccharide issues, mold issues, pesticides, herbicides. That's charcoal is really good at that. Zeolites for mold and pesticides and herbicides. Clays for mold healing. The gut lining is really important with that clay too. So.
Beautiful. So we've kind of been down this long and winding road talking about detoxification. I'm wondering if you can just kind of now try to summarize the key things that you think are most important from a clinical consideration perspective to help us optimize our detoxification capacity.
Sure. I really think it comes down to dealing with the inflammation. And that means dealing with the ringleader, the orchestrator, that's the mast cell. So don't neglect that. That was pretty new for me. Bob gave me an assignment about 2 weeks before we were going to present in Sanibel. He said, Kelly, I want you to learn everything you can about the mast cell. And I went, mast cell, medical school, we learn, okay. And then you start looking at where it's found in our body and what it's doing, and really respecting that and making sure that we're using compounds you can use compounds to help the degranulation and just calm it down. But looking at your environment, environment. That's what my family and I spend our money on. EMF, making sure that we're protected, and clean air, clean water, clean food. That's really going to have the most bang for your buck with that. And then the second thing I'd say is properly using and making the acetyl-CoA. Look at all the widespread effects that it has and where it needs to go. And we're in a closed system, so we don't have bountiful amounts of acetyl-CoA. So if we're degranulating all the time, we have copious amounts of histamine, and we're using all of our acetyl-CoA, we're stealing it to mop it up. Well, yeah, you're not going to have much energy, and you're not going to make your bile perhaps. So those are really the key points.
So the question I always wrap up with is, what are some of the things that you do on a daily basis in support of your own health maintenance?
Sure. So in my book, nothing trumps nutrition, hydration, rest, and peace. Nothing will trump those. So nutrition, I like to get everything that I need from food. Sometimes it's hard. I do take pantethine. I have to take that. I have really significant pain problems. And then I do take PC, phosphatidylcholine, sometimes. I monitor my phase angle. I also will take the occasional acetylcarnitine just to make sure, because my ACAT genes, I really have the quintessential acetylation issues that the Lyme that we were presented at Poland. That's really me. So I know how to take care of that. I make sure that I'm getting the bioavailable copper. I'm avoiding iron. I take my binder. I definitely take my binder. In terms of hydration, I am a huge fan of Echo hydrogen water. Hydrogen water puts out the fire of the nasty hydroxyl radical. When you have too much iron in your system, you're going to be producing a ton of hydroxyl radical. I drink just copious amounts of it, and it really has helped, and so does my family.
Is that one of the products that's a tablet that you put into water, or is that a device? Tell us a little about that.
So it's a device. It's a countertop device. They also have tablets, and they also have eye drops. So I take it when I travel. I really feel a difference when I don't take it. And again, I have iron issues. I have HFE. I have things that may put me at a really high disadvantage of having a lot more hydroxyl radicals. But my husband, who has perfect genetics and perfect everything, he really notices the difference as well. So that's one of the things I absolutely believe in. And then rest in peace. So I travel a lot. I teach a lot. If there's practitioners out there who want to learn more about this, because it's taught in 2.5 days. So we just did something monumental here, Scott. We taught this in 45 minutes. So really, we're doing a seminar on this in October in Austin. You can go to PHP Ltd, and you can spend 2.5 days with me and Dr. Eric Balkavage, and you can learn about this in a broader sense, not just trying to drink from a fire hose. But really, I travel a lot. And so what I use is Brain Tap. It's called Brain Tap. And it helps me get into a parasympathetic state. Have you heard of Brain Tap before?
It's actually my next podcast.
No way. So I just got done using my Brain Tap.
I have one too.
I travel with it because I'm not a meditator. I can't sit still. I do the program that comes with it. I just pick what I need. Today I needed focus. So I did a focus program.
It's actually, I heard about it years ago, but then 3 people mentioned it to me within just a couple of weeks, including one who was a medical health professional who had done lots of things in the realm of Lyme and mold and health-wise doing really well, and got one of the Brain Tap devices and said that he noticed a huge improvement from an energy perspective and just really felt that it was very, very health supporting. And so that got me interested enough to say, okay, I need to explore it. And so I did get one, and Dr. Patrick Porter is going to be the next guest. So.
Yeah, it's my buddy. So you know what, I'm always a cynic. So when I got the Brain Tap, I thought, oh, okay. But I wear an Oura ring, and I started to track my sleep. My deep sleep doubled. And I just did 20-minute session, like maybe 3 times a week. So rest in peace. There we go. That's my Brain Tap. That's how I do it. So
I love it. That's so great. So for practitioners listening, you talked about some of the trainings that you're doing. If there are patients that are listening, do you do consultations? How can they learn more about your work?
Sure. So you can learn everything about me by going to drkellybeatlyme.com. So DrKelly, beatlyme.com. And I put all my information, all my speaking events, how to make an appointment with me. I put it all in there.
Beautiful, beautiful. This has been super fun. It was definitely a lot to cover in a short period of time, but I think the important thing, obviously, the 11th commandment, taking the binders, is important, but then this whole idea of phase 2.5 to really optimize the potential binding capacity of these binders is something that I don't think a lot of people talk about. And like I mentioned, that it first came into my mind from talking with Dr. Shade in the podcast that we did a few months ago. And so I think it is really an important area for people to explore. And so thank you so much for taking time today to share all of your knowledge and information. I know it's just a piece of the knowledge that you have, because it's obvious that you have a lot of depth in this area. And I just want to thank you for spending time with us and sharing a lot of that information today.
Thank you, Scott. It's been really fun.
To learn more about today's guest, visit drkellybeatlyme.com. That's drkelly, Kelly, beatlyme.com. drkellybeatlyme.com. Thanks for your interest in today's show. If you'd like to follow me on Facebook or Twitter, you can find me there as Better Health Guy. To support the show, please visit betterhealthguy.com/donate. If you'd like to be added to my newsletter, visit betterhealthguy.com/newsletters. And this and other shows can be found on YouTube, iTunes, Google Play, Stitcher, and Spotify.
Thanks for listening to this Better Health Guy blogcast with Scott, your Better Health Guy. To check out additional shows and learn more about Scott's personal journey to better health, please visit betterhealthguy.com.